Welcome to the next in the KDIGO Symptom-Based Complications in Dialysis webinar series. Today's episode is episode 3, Optimizing Management of Psychological Symptoms in Dialysis. One housekeeping note before we get started. Please submit your questions and complete this episode's questionnaire via Slido at slido.com/optimizing. We have a jam-packed agenda, so we'll get right to it. Our speakers today are Dr. Michael Germain, Bay State, UMass, Tufts University in the United States. Our second speaker today is Dr. Daniel Cukor at the Rogozin Institute in New York City, United States. Without further ado, I'll turn things over to Dr. Germain. Go ahead.
Well, thank you for inviting me today to talk about fatigue in people with chronic kidney disease. It's a major problem for our patients, both with dialysis and pre-dialysis, as it's one of their number one problematic symptoms. And it's a sort of problem which you can't seem to get ahead of for many patients. And so it's kind of like that old Greek myth where they're pushing the rock uphill and never make any progress. I have no conflict of interest disclosures on this topic. So this will be interesting when we get to the discussion part, because fatigue, like a few other dialysis or CKD related symptoms, is a subjective symptom. And it's commingled with other symptoms which could be considered psychological. So is fatigue psychological? Is it physical, or is it both? Because fatigue is associated with depression and CKD, and fatigue is a component of depression, although it doesn't fit into some of the scores that use in depression. Psychiatrists, psychologists tell me, they commonly see fatigue as part of the complex of symptoms with depression. So it can definitely be mixed in these patients, but it is a subjective feeling. And, some patients say they can do things to ameliorate fatigue, such as taking caffeine or keeping active. Fatigue is strongly associated also with pain and itch, which are also subjective symptoms. There's no blood test for these symptoms, but we're pretty sure that they're related to physiologic changes, in particular uremic toxins. However, psychological symptoms are associated with physical changes in the brain too. So it's kind of an unanswerable question. I think the things are tied together closely. There's also the issue of how much fatigue is related to weakness. So is it, when the patient says fatigue, are they talking about feeling weak? Because we know there's significant muscle dysfunction, mitochondrial energy defects in people with chronic kidney disease. So muscle strength is significantly diminished and only partly improved with aerobic and resistance training. Max O2 is also significantly diminished and only partially corrected with training. So as a person does try to do any activities, they're going to feel tired because of those two things. And those deficits worsen as the GFR declines. Transplant tends to correct all these deficits almost 100%. And so, clearly it is related to uremia and likely uremic toxins. So it really is, if you believe in the whole body theory, that there is no separation between the mind and the body, then there really is no difference. And it doesn't really matter if you consider it psychological or physical or both. So difference between depression and fatigue. Well, situational depression, which again is not in the DSM, but is real as far as what psychiatrists and psychologists tell me, can result in can be a result of dialysis, psychological stresses and symptoms. And pain, fatigue, and itch, which are all in this complex, definitely work together to cause fatigue or, are associated with fatigue. So the feeling of, having no interest in anything is a symptom of depression, but it's not the same thing as fatigue. And the lack of motivation is a symptom of depression, but it's not fatigue. So if you can unbundle those with the patient as you talk to them, you might get a better handle if depression is involved. But my own experience, not being a psychologist or a psychiatrist, is that patients sometimes cannot really unbundle that in their mind. And, they just say, I feel tired or I lack an appetite. And if you ask them if they're depressed, they don't think they're depressed, and they may not have some of those other symptoms. So it gets pretty hard sometimes to tell. Not able to get yourself up to do tasks that occur with fatigue, but the patient would like to be active, but can't because of the fatigue. So that's a little different than depression. So one of my patients that I was talking to recently just started dialysis, and he definitely feels fatigue, both pre-dialysis, and he says that the dialysis is starting to definitely improve his overall fatigue. But he says the fatigue of chronic kidney disease is unlike any other experience that he's ever had, except with mild hypoglycemia, being a diabetic. He describes it pulls at you. It creates an overwhelming desire to sleep, so he can sleep from 11 a.m. post-dialysis till the next morning. He says, if I fight it and don't fall asleep, it will get better, and I can do some activities later in the day and then not sleep away the whole day. And he says that coffee helps. So that's one man's experience. So managing the symptoms can help maintain quality of life. So, if you're having severe post-dialysis fatigue, maybe go to the night shift, because then they can just sleep on dialysis. It can also be related to how much fluid they take off. And by the way, we know that 2/3 of dialysis patients are not at the correct dry weight based on what their weight is after they get a good kidney transplant. So a third of our patients are under dialyzed and feel weak because they're, always dry, always volume depleted. So again, the support of family, people understanding it, is very helpful. When the family doesn't understand, then it creates more stress and makes the symptoms worse. They don't know why the patient can't do things. They look okay to them, and they thought dialysis would make them all better. And so the family may not have good understanding, and that creates a lot of stress. So a subjective sense of weakness, lack of energy, tiredness, and this is reported from big surveys, internationally, anywhere from 60 to 97% of patients have these symptoms. And it's worse with exertion and mental problems, stress, psychosocial stress increases it and causes decreased functionability. So in a systematic review of 59 studies to estimate prevalence of symptoms in dialysis patients, it was very, very common. 91% of patients associated with disturbed sleep, and in a little less than half as restless leg in 30%. And pruritus is also a big component of this, very big component of being commingled with fatigue. Because if you don't sleep, then you're going to have more fatigue. And many of these things are associated with sleep disorders. And there's many reasons for sleep disorders besides uremia, also obesity, sleep apnea, so many other reasons for sleep disturbances. But it is considered by patients and caregivers one of the top prior areas in research because there's very little known treatment or things that we can help patients with. Almost every patient experiences fatigue after completing their dialysis. It interferes with their activities of daily living, and many patients attempt to time their dialysis treatments to manage the fatigue. But it pretty much takes up the whole day. It's crazy because dialysis does so much to your body. It can make you weak because it's like a workout and it's working out your heart. So this is kind of some of the descriptions patients have. Interestingly, healthcare providers are largely unaware of the presence and severity of fatigue. Why? Because they don't ask the patients. The patients often don't tell them because they don't know it's related to their renal failure. So they don't think it's, it's the nephrologist's business to know this. And by the way, this has to do with sleep and depression and restless leg syndrome and pruritus. They're all under-recognized by the clinician because the patient doesn't know, we don't ask, and the clinic and the patient doesn't think it's the nephrologist's area. And it's challenging because up till recently, there's a lack of reliable, valid scales, overlap with other symptoms we talked about, and variability, and also the fact that comorbidities such as heart failure, diabetes, side effects from medicines, which our patients take a ton of, can also be causing some of these symptoms. So a lot of you may be familiar with the SONG initiative. It's a multi-year international study where we bring together patients, caregivers, clinicians, and we look at patient-focused issues for patients with chronic kidney disease, including transplant, dialysis, and CKD. So I was involved in this program for fatigue. And, I won't go through this, but I'll leave the slide for you where it describes a lot of the, symptoms that patients describe with fatigue. And some of it is like, it's all encompassing, again, as I said, the connections with physiologic changes, the severity and frequency, impact on quality of life, and contributing to life participation. So these are some of the themes that came out of some of the interviews that we did and some of the workshops we did in this area. And then, looking at how to measure fatigue, this became a big focus for our meeting. How you talk to the patient, avoiding suggestive wording, the fact that patients are not cognitively all with it when they're on dialysis. And so discussing this with them on dialysis is very challenging. And the patients, of course, have told us they're giving surveys up the wazoo, and they really don't like getting a lot of surveys. So it has to be very simple. Now, how about muscle weakness? As I mentioned, this is a distinct abnormality and is seen only in uremia, this abnormal mitochondrial failure of energy in the muscle and associated with uremic metabolites or uremic toxins. Again, the SONG initiative talked about listening the uniqueness of fatigue, captioning severity and frequency, some of the things that we talked about on the other slide. And so we began to look at, getting a measure for fatigue, and this is what we came up with. So now this is a fatigue score that was developed by patients, clinicians, and then it was tested and validated in a patient population across the world. And so now this is a validated measure that I believe some studies are currently using. So you can see it's very simple. It's a 9-point scale, and 3 points for severe symptom of feeling tired, lack of energy, 3 points if it's severe, and did fatigue limit your usual activities 3. So if you get the highest score, it would be 9. And as you can see from this slide, there are many reasons for fatigue that we believe are maybe all happening together. So the physiologic factors, anemia, malnutrition, uremia, hyperparathyroidism, medications, the inflammatory state, which is huge in people on dialysis, physical activity, the fatigue begets lack of being able to do exercise or be active, and then that being inactive leads to more fatigue. So it's a vicious circle. Comorbidities, and then all the psychosocial factors. As people get older, they do naturally get more tired with activity. And then on top of that, if you have an 80-year-old that's been experiencing that and then gets renal failure, it's going to multiply that. And then the dialysis related factors, which are somewhat modifiable, and the stress, anxiety, sleep disturbances, we talked about those factors too. So cytokines, again, I'm not going to go through this, but multiple cytokines are known to affect patients with chronic kidney disease, and definitely are associated with symptoms of fatigue and weakness, energy production in the muscle, so muscle weakness and decreased oxygen, max oxygen consumption. And so, many of these cytokines are known to be very elevated in people with chronic kidney disease. So we want to take a multidisciplinary approach to improving fatigue. And first is to be aware of it. So make sure that clinicians, the doctors are aware of it, start to measure it, start to ask people about fatigue routinely when you have your visits with them and on dialysis, perhaps make it part of the process of the dialysis unit. If we can do things to make dialysis better, like low temperature, we know helps. Trying to get them to the dry weight, which is a totally different and separate talk, but there are ways that we can do to try to get a more accurate dry weight on these patients. Longer, more frequent dialysis seems to have some benefit, but in the randomized controlled trials, when this was done, it wasn't as much improvement as you might have hoped for. The improvement was quite modest, if there at all, with those with nocturnal dialysis or frequent dialysis. So nutritional therapy, improving sleep, exercise, stress management, treating depression, pacing themselves in their daily activities, and getting people to an individualized hemoglobin can be very helpful too. So right now we have unit-wide hemoglobin goals, and everyone is at the same goal. Well, imagine, if you have a younger patient who really has a lot to do, has a job, wants to still participate in exercise and activities, they might feel best at a hemoglobin of 12. And there's no reason we shouldn't target their hemoglobin there. And maybe for a person who's in the nursing home and is bedbound or wheelchair bound, they don't need a hemoglobin of 12, maybe just 9 or 10 is adequate. And that might decrease the risk of higher doses of erythropoietin that we know about. Antidepressants, treating anxiety, levocarnitine, these are all, kind of hypothesis generating. There isn't a lot of evidence for this. Human growth hormone, using amphetamines like Adderall, again, maybe, just no evidence for it. So basically we have no evidence for any treatment for fatigue because there haven't really been any significant trials. And getting the patient's family and caregivers to understand that these people have very limited, very limited abilities, and that should be recognized. They should be compassionate about it. So maintaining quality of life, this is really what it's all about for patients. And again, these are some of the things that patients tell us. The key things were managing their symptoms, getting to the right dry weight, maybe switching to the night shift, maybe switching to peritoneal dialysis for some people, relationship with their healthcare providers, make sure that they know the doctor will listen to them and try to help them so they can raise these issues with the clinician. And relationship with the family. Again, the support of the family helps them go through a lot. So if they have the symptoms, they're not as burdensome for the patient if they feel the family supports and understands them. So if you look at this complex, you have a debilitating, exhausting burden of dialysis with all these sorts of effects that you see on the upper left. This leads to restricted life depression, participation, which involves, being frustrated. Some of the things they enjoy, they don't enjoy anymore. You can imagine this might lead to a situational depression. And again, if the family and other people at work, if they work, are not really understanding of them, they're afraid they're being judged for their need to rest, maybe take a nap, maybe not be able to help as much in the family, especially if they have small children, failing to meet expectations. That can just make things worse for the patient. So you can see how this can all be a vicious circle. And again, the relationship with your significant other can be a huge problem for patients. So they can't work anymore sometimes and provide for the family, rely on others. Sexual dysfunction is huge here and totally tied into fatigue, because sometimes it's a lack of libido, both for men or women. Sometimes it's, for men, a problem with erection. Sometimes for women, it's a problem with being able to, have lubrication related to sexual dysfunction. But sometimes it's just a lack of energy. They just, they want to have sex. They're interested in sex. They may be able to even get an erection, but they just don't have the energy to do it. And fatigue, I'm sure everyone's experienced that. You have a really hard day, you work really hard, you just want to get into bed, and maybe, sex is not the first thing on your mind and you just don't feel like it that day. And then failing as a parent. So again, education, reassurance. Fatigue is real, not laziness. Focus on goal attainment, adjust energy expenditures. In other words, pace yourself, exercise, as much as you can, but don't push yourself. But a little bit of exercise, a little bit of walk around the yard or around the block could be very helpful. And then look at other comorbids. Do they have heart failure? And treating heart failure can be huge at improving fatigue and quality of life. The same with COPD. Maybe they need continuous oxygen or treatment of their lung disease. Minimize medications that can cause fatigue. So a lot of the medications that we use for itch and neuropathy, such as gabapentin or pregabalin, they need to be severely dose adjusted with renal failure. And if the dose goes too high, they are going to feel symptoms that are very similar to fatigue. And address some of these psychosocial problems, such as depression, which we're going to hear about later. So we've talked about how to measure fatigue. We've talked about maybe what causes fatigue in people with chronic kidney disease, also the associations with other symptoms with fatigue. And we talked about treatment. But to summarize, there really is no treatment. These things we've talked about, like amphetamines, Adderall, no evidence, but something to think about. More frequent dialysis, we talked about that. Treatment of anemia, we talked about that. Kidney transplant will reverse it in most cases. Anti-inflammatory agents might help if there's musculoskeletal pain, and other interventions have been suggested. Levocarnitine, Modafilil is also been suggested, but really there's not good evidence for these. And at the end, I'll just leave you with these references to review, and there'll be some supplementary slides to look at also if you review the slides. So thank you very much for taking the time today, and we'll have time for some questions later. Thanks.
Thanks, Mike. That was a very interesting talk. Hi, everyone. My name is Daniel Cukor. I'm a clinical psychologist working here in New York. And today I will be talking about optimizing management of psychological symptoms in dialysis with a particular focus on anxiety and depression. Here are my disclosures. And I'd like to start the talk by thinking about the experience of the patient who's on dialysis and the demands of life on dialysis. So we know that stress is defined as when the perceived demand exceeds the perceived resources. And let's just spend for a moment thinking about all of the demand that is placed upon our patients. So in addition to all of the regular life demands that we all have, the person who's on dialysis also has these additional challenges going on in their life. They have what I've described here as illness treatment effects, not feeling well, going to treatment, having to organize your life around coming in for treatment. All of those challenges, are profound actually in a dialysis patient. And we know that the symptom burden, the treatment burden, is very high in dialysis patients, and that can cause a profound amount of change in their life. Similarly, there's a lot of role and relationship changes as well. A person might have been working, now they're stopping working. They might have been kind of healthy and vibrant beforehand, and now they require more care. And that can have a profound effect on how they see themselves and how they interact with others, in not only in their kind of families and in their work lives, but also in the dialysis center itself. And that there's a relationship with the nurses, with the technicians, with the nephrologist. And sometimes those relationships are supportive and sometimes those are challenging. And as a dialysis patient, you don't really have the opportunity or the power to navigate or negotiate those relationships, perhaps the way that they are accustomed to. So that can be a challenge for people as well. And then there's all the lifestyle changes. There's dietary restrictions, fluid restrictions, extra appointments, doctor's appointments, in addition to all of the not feeling well and all of the dialysis prescription. So there's a really large burden placed upon all of patients who are going through dialysis. And one way to think about the challenge that people go through is the greater the gap between our anticipated life and our actual life, the greater room for disappointment. So if people had an expectation of how they would be spending their time and the way that they're actually spending their time is quite different, or the way that they'd be feeling, or the way that they would be able to interact with the world around them is really different than the way that it is, that opens the door for disappointment and for psychological distress. So if we look at some of the data as to what is important to dialysis patients, here's a study from a few years ago, but I think very telling that more than 50% of patients report difficulty with mood, sexual issues, sleep difficulty, pain, skin issues, gastrointestinal issues. There's just a high symptom burden, which is really common. And then another study, which is a bit more recent, asked people, how often do you experience symptoms? And then what do you believe are the most important mood symptoms that should be targets of intervention? So this particular chart is how the symptoms experienced in the past month, but it's a pretty similar list as to what the targets of intervention should be. And we can see that people, by and large, dialysis patients are feeling anxious, angry, depressed, and worried. And obviously there's an overlap between all of those different feelings and those different mood states, but we get a sense of this is a really difficult illness to cope with. In the way that I think about depression and the interplay of other psychosocial constructs, I really think of depression as being at the nexus of really like a chain of different symptoms that people can experience. And here I have highlighted, sleep difficulty. Certainly there's conceptual overlap between depression and sleep difficulty. Tiredness, not being able to sleep well is a symptom of depression, but also all of the kind of physiological changes of dialysis, plus, the irregular schedule that dialysis patients have, all contribute to sleep difficulty. And I think Dr. Mehrotra spoke about that really eloquently. I have here fatigue, which we just heard about from Dr. Germain. And then there's issues of pain, sexual difficulty, and anxiety, which all have kind of this conceptual overlap with depression. And then I have listed here as a separate entity symptom burden that, in addition to whatever symptoms somebody might have, if you're depressed, I think you experience those symptoms as a bit more intense. It's just harder to cope with whatever difficulties you might be going through if you're also experiencing depression. And I often challenge people to think about, how long could you feel depressed and not sleep well before some of these other things become part of your clinical presentation as well. So they're both conceptually overlap one another. They kind of coexist together, but they also can lead very easily from one to the other. And, this is, I think, the daily reality of many of the patients that we are talking with. So I ask them, how they're doing. It's a complex answer. It's the interaction of all of these things, perhaps at different stages at the moment that we're speaking to them. But for a lot of people, this is what's at play. If we look at the actual prevalence of depression, so it really varies depending on which particular subpopulation and which tool we're using. But I think from a broader perspective, I would say roughly a quarter of the people seem to be diagnosed with a major depressive disorder on structured clinical interview. And about 50% of people report what we call elevated depressive affect, or, high scores on self-report measures. So, kind of consistently across, all different types of populations, we generally see this pattern of depression prevalence. And the impact of depression in dialysis is really significant. We know that there's higher rates of infection in people who are depressed. We've seen, analyses that are associated with increased hospitalization, lower quality of life, increased morbidity and mortality. In fact, in one study, they estimate the risk of death is an additional more than 50% in people that have a comorbid diagnosis of depression. So just to be very specific, when we talk about what a major depressive disorder is, as defined by the DSM-5, so here are the symptom criteria for major depressive disorder. So you need to have at least 5 of the 9 nearly present every day in a specific 2-week period. And the first 2, you need to have 1 of the first 2. The first one is depressed mood or irritable most of the day, nearly every day, as indicated by subjective mood, the person reports feeling sad or that they're tearful, if it's an observation made by others. And then they have to have decreased interest or pleasure in most activities most of the day. And then there are additional symptoms that you need to have some of significant weight change or change in appetite, a change in sleep, a change in activity level, fatigue, feelings of guilt and worthlessness, difficulties in concentration, and increased thoughts of suicidality or death. And obviously in people that are, let's say, physically feeling not well, we might see elevations, we might see changes in fatigue, changes in sleep, but certainly the ones around feelings of guilt and worthlessness and thoughts of death and suicide are rather unique to depression, and I think can be quite helpful in trying to tease apart what the clinical presentation that you are seeing. And for here in particular, we're looking at changes in these constructs. So if somebody's new to dialysis, then there might be a change due to dialysis. But if somebody's kind of stable on dialysis and there's really been no medical change, and then they all of a sudden are finding that they sleep more frequently or can't sleep at night, so then we would be more likely to think about those symptoms as being kind of more related to the depressive disorder. So in clinical practice, we use a lot of screening tools, and here's just a few comments about some of the commonly used one. The PHQ-9, the Patient Health Questionnaire 9, is ever growing in popularity and lines up to the 9 questions related to the 9 symptoms that I just showed. So it's very related to diagnosis. Another measure is the quiz, which has been validated. And one of the strengths of it is that there is a clinician version as well. So you can kind of use that, that scale, and then the clinician can sit with the person and kind of come up with a formal diagnosis. And then there's the Beck Depression Inventory, which is not free to use. It has more questions, and but perhaps provides a bit more insight into the severity of the depression than simply just marking as whether it's present or absent. And then there are some other scales that are used, I think, a little less commonly. So just to digress for a moment, when we started to screen for depression in any population, we have to be very thoughtful of what a 0 or a low score means on that self-report scale. And whenever I see someone that scores low, here are the thoughts that I kind of go through. That 0 or that low score might indicate a true absence of anhedonia and low mood, in particular if it's like the PHQ-2 that you've given to someone, and it asks about their lack of ability to enjoy things or their subjective experience of feeling down. So it could be that they're just not feeling those symptoms, and that's why they've scored it that way. It also could be that they don't really understand the question's intent. There's a health literacy issue. There could be a language issue. So what did the person understand that question to mean, and how did they answer that question? Sometimes are quite different than what we might expect. There also might be a lack of a desire to discuss a mental health issue. The 0 might really just mean it's none of your business. I don't want to talk about this with you. And that is quite different than saying, I don't have those symptoms. And finally, the 0 might be just an indication that the person doesn't have any faith that the response is going to be commensurate with them reaching out for help. So if you've completed this form, as part of a quality improvement project or as part of quarterly reporting, and you've indicated that you need help, and then you get a printout which says, here are local mental health resources, and it's the same printout every time, and you're not successful at connecting, why would you keep on reporting the symptoms, if that's the only response that's going to happen? So I think we have to be particularly thoughtful when people report that they're not depressed, being thoughtful about what it might be, what might have triggered their answers on a self-report. It is more common than not, if I get a referral for depression and I look back in the chart, that the last kind of standard interview or the standard questionnaire that they've completed indicates a very low score. And then when I go and sit with them, it does not reflect the reality that I see when I sit with them. Along those lines, I'd like to kind of just talk about for a moment the components of the identification and treatment of depression. This is not necessarily in the dialysis population, but this is in the community at large. And this is what I would call, gold standard care. In that if a patient is identified with low mood, the next step is diagnosing depression. So just scoring high in an inventory is not the same thing as actually having a formal diagnosis of depression. And then once somebody has diagnosed that person with depression, they begin a course of what I've described here as stepped care. And stepped care really means that you have to be prepared for this to be an iterative process. Many of the things that we do on our first attempt are not helpful for patients, and we need to think of a plan from the beginning that incorporates a multi-pronged or multi-stepped approach. And if we tell people from the beginning, look, let's try this medication, let's try this psychotherapeutic technique, but let's reevaluate in a few months, and if it's not helpful, let's try something else. I think that sets the expectation well for the patients as to how they are able to kind of think about getting their care, and that there's a bit of trial and error involved in finding the right types of care for the symptoms that they're experiencing. And then if you have successfully treated the depression, so sometimes thinking back about that, those cogs that are kind of all interconnected in our patients. So sometimes when you treat depression, those other things begin to improve on their own. And sometimes they require some direct clinical attention as well. So if the person has residual insomnia, if the person has residual pain, those might become areas of clinical focus. And then I think once you've treated someone, it's always important to kind of document and to think about, what has the change actually been, and then set up some sort of program for relapse prevention and for monitoring. So empowering your patient to know what to do if they start to feel bad again. As we say, in medicine, an ounce of prevention is worth more than a pound of cure. If you can help somebody who is just starting to feel the signs and symptoms of that they're slipping into a depression again, it's a much easier time to intervene than somebody who's really kind of in the midst of a full depressive episode. So to begin thinking about treatment of depression in dialysis patients, I'd like to start with treatment of depression, outside of dialysis in general populations. And there's many clinical guidelines about how to treat depression. They are all very similar, with perhaps some different recommendations about moderate versus severe or mild versus moderate. But the first-line therapies for major depression in general incorporate two recommendations. The first one is an antidepressant drug therapy, a selective reuptake inhibitor, formerly known as SSRIs, but it's not only serotonin that these drugs work on, or a psychotherapy intervention, with the most well-studied being cognitive behavioral therapy, particularly described or adapted for depression. And selective reuptake inhibitors are FDA approved for depression, anxiety, eating disorders, premenstrual pain, and commonly used for insomnia, behavioral agitation, irritable bowel, and headaches. And if you think again about the nexus of symptoms that our patients present, you could understand why these drugs might be very helpful for people and hit on more than perhaps just the single depression target, but on some of these other areas that are problematic for them as well. Similarly, if we look at cognitive behavioral therapy, it has been demonstrated to be helpful for depression, anxiety disorders, eating disorders, insomnia, pain, sexual difficulty, and adherence to medical prescriptions. So there, again, is ample opportunity for our patients to benefit from this intervention as well. In thinking about how to apply the treatment recommendations in general for depression to patients with end-stage renal disease who are on dialysis, unfortunately, there's very little data. There's been a recent review which has been done by the VA, and essentially they have come up with, they have reviewed the studies that have at least fair quality of evidence, and they report that there's two studies that report cognitive behavioral therapy outperforms control, and that there's only one study that has been done on psychopharmacological approaches in patients who have end-stage renal disease, and we'll spend some time kind of talking about that study now. That study is known as the ASCEND trial, which stands for the trial of sertraline and cognitive behavioral therapy in patients with end-stage renal disease. It was run by Dr. Mehrotra and a variety of our colleagues. I participated in that trial as well. And the goal was really to compare the efficacy of cognitive behavioral therapy versus sertraline for treating depression in patients receiving hemodialysis. And just a bit about our method, we approached over 2,800 people for screening at 41 different dialysis facilities in 3 geographic areas in the United States. For this particular study, we used the Beck Depression Inventory and a score of 15 or above as a positive screen. And we had 636 people screen positive. For those that met the inclusion criteria, only about half of our population that screened positive ultimately met all of our inclusion criteria. And then of those, less than half ultimately were randomized to the study, which was the phase 2 part of our study, which was the actual depression intervention. And in that part of the study, they were randomized to either sertraline titrated up to 150 milligrams daily, or 10 sessions of cognitive behavioral therapy, which was delivered chairside at the dialysis center. And here is the kind of main result of the paper. And what you can see is this line represents kind of the threshold for depression. And we can see roughly that both groups go from being depressed to at least the mean scores to kind of crossing that threshold. And you can see a slight advantage for the sertraline group over the cognitive behavioral therapy group. And if we look at the data a bit more carefully, we can see that there's less than 1 point difference between the CBT and sertraline groups. And then if we look at the adverse events, we can see that even though there's not a difference in the serious adverse events, but in the non-serious adverse events, there seems to be about a 3 times more likely chance of having non-serious side effects in the sertraline group as opposed to the cognitive behavioral therapy group. So what we concluded from there is that both treatments are effective for treating depression, and that, the relative efficacy for either one, I guess it really depends on, there wasn't a clear winner, I would say, and it becomes a choice of patient preference or a particular, patient's presenting needs. So when we think about translating the ASCEND trial to clinical practice, a few questions come up, which I think are worthy of considering. Why was it such a small percentage of people enrolled? We screened nearly 3,000 to enroll 120. Does this represent clinical practice where these people are perhaps more severe, more engaged? Obviously, we're not really sure about the people that we didn't enroll. So it's just kind of remain, I guess it's a standard question whenever you're comparing clinical trials to clinical practice. And again, similarly, this is a time-limited treatment. Treatment began and end, based upon a protocol, not necessarily by, patient response. So how would that be different if we did kind of standard clinical practice? And also, people that would agree to be randomized to either medication or psychotherapy, does that represent kind of a usual slice of the patients that we would see, or is this a particular subgroup of people? And then, about 60% of the people did not get, did not remit, did not cross that line to feeling, to being not depressed. So, from this study, we don't really have any suggestion about what to do with those people, but we do know, like I said earlier, that this really needs to be an iterative process, that just one initial treatment is probably not going to be sufficient for everybody that you're going to treat. And then similarly, what about combination treatment? We compared one against the other. In clinical practice, we often do them in a combination. So how would that work in our patient population? I think these are really important questions that are still outstanding, and we need to answer them within the dialysis population. I'd like to change focus now and focus on anxiety. And there's much smaller amount of data available on anxiety disorders, but it actually looks pretty similar to the type of data that we saw on depression. So we see that in self-reports, the range of self-report scores are, somewhere between 38 and 50% of people will report ongoing, point prevalence of anxiety. And then if we look at the clinician rated, there's only 2 studies that I'm aware of that have clinician rated. One is 16%, one is 26%, different populations. But again, I think very similar to depression, where we could say that there is a substantive minority of people that would meet a clinical diagnosis of anxiety. And then there's many more people that are experiencing a lot of symptom burden related to anxiety symptoms. Why is it important to think about anxiety? It is important because we know that healthcare utilization and emergency room visits are impacted by anxiety. There's a disorder called illness anxiety disorder, which is not technically an anxiety disorder, but a somatoform disorder. But anxiety is a hallmark feature. And we know that in that diagnosis, people are inappropriately low and high utilizers of medical care. In our medical population, there's such a focus on appropriate use of medical resources that understanding if there's a subgroup of people that are either avoidant or high utilizers would be very helpful to think about, the psychological interventions to help kind of bring their healthcare utilization to a more medically appropriate level. We don't really know if it impacts dialysis prescription adherence. I certainly have my conjecture that people who are anxious and people who are sensitive to physiological symptoms, that dialysis treatment itself is particularly challenging for them. And then if we focus in on the ends of treatment, when a lot of people are experiencing more hemodynamic shifts and some more symptoms, that maybe perhaps some of the people that are leaving dialysis early or constantly cutting their time might really be, people who are extremely sensitive to symptoms that are trying to do their best to avoid experiencing those symptoms because they experience them as being more distressful than other people on dialysis. We have some data that says that anxiety independent of depression negatively impacts quality of life. There's an association in a large-scale study looking at mortality, again, independent of depression. And again, there might also be an association. We're doing some work now looking at whether the experience of symptoms is in fact more exacerbated in people that have anxiety as part of their profile. That if you are worried about all of your symptoms, it makes sense that you would have more distress when you experience some of those symptoms as opposed to people who are less concerned about having those particular symptoms. So I think to bring it all together, there's a bidirectional relationship between kidney disease and depression and anxiety. The worse your kidney health is, the worse you feel, the more likely you are to have depression and anxiety. And the more depressed and anxious you are, the more likely it is to kind of negatively feed back into your kidney disease, either directly perhaps or indirectly through patient behavior. But there's this loop that begins to form, and then it can become a vicious cycle. So, I advocate constantly for thinking of depression and anxiety as appropriate clinical targets. And it's not only because they are contributors to negative quality of life and all of the other things that I had mentioned earlier, but also because I think it's not just an extra value in care, but it's really part of holistic care. That if you really want to provide good care for, good renal care for your patients, you can't afford to ignore their mental health symptoms. So I'd like to thank you very much for your time and attention today. Here are some of the additional references that I had referred to during my talk. And I think now we'll have an opportunity for some questions and answers. Thanks.
Thank you very much. At this time, we'll get into our questions and answers. Please submit your questions and complete this episode's questionnaire via Slido at slido.com/optimizing. Now I'll turn things over to Dr. Germain. Go ahead.
I don't know if you also believe, like I do, that there isn't this black line separation between the brain and the rest of the body, and the experience that people have. And so it's hard to say this is psychological, this is physical sometimes. And I think dialysis patients are kind of the poster child for that. But if we agreed on that, if we don't agree, then it'd be good to hear your perspective. But if we agree on that, I think maybe just how do we practically approach this? That would be most useful for the audience. Like, how does a psychiatrist or psychologist work with the nephrologist or the primary care person on untangling some of this, and what do you do first, for these patients, or how do you approach it?
Yeah, I think I'd probably go a step further, that it's an unhelpful construct that we are stuck with in medicine of trying to allocate whether this is psychological or physiological. And then the more we learn about medicine, the more we realize that's a construct that we are putting upon human existence more than it actually reflecting biological reality. So I certainly believe that there's conceptual overlap between fatigue and depression, and that even if we had perfect diagnostic tools, there is actually an overlap between those things. You can be exhausted, which can lead to depression. You can be depressed and not exhausted, depressed and exhausted. They co-occur. They're not the exact same thing, but certainly there's elements of each in one another.
Right. So then that's a good way to put it. You said it better than I did. So now what would be the practical approach for us to manage a patient, let's just say on dialysis, to keep it simple? They're dialysis patient, they're telling us that they feel very weak and tired after dialysis, but they're also saying their quality of life has deteriorated quite a bit. And there's this, like they do the, the depression scores in the dialysis unit, and they score high on the depression score. So, the social worker suggests that we refer the patient to you because they have a high depression score. So you take it from there.
Yeah, so I think, there's a difference between scoring high on a symptom inventory and actually having a diagnosis. The person who is going to take responsibility for the treatment of the patient needs to make their own determination as to whether this person actually has the diagnosis, or maybe just has some symptoms of that diagnosis, or has some overlap from a different or similar diagnosis. And that really should be the focus of clinical attention. I think, to me, the challenge is, there's still a profound stigma around mental health. And if the social worker identifies somebody as needing more support, or as perhaps depressed and requiring further evaluation, it's very difficult. Step one, it's difficult to get many patients to accept that suggestion and to go and pursue outside treatment. And then number two, if they are motivated to pursue outside treatment, our healthcare system does not make it easy to find a mental health professional who accepts your insurance, who will readily see you and provide competent care. And then, when you're a dialysis patient, you are certainly extremely limited in terms of your ability to be available for certain types of appointments. And, you can't just get an appointment 3 weeks from Monday at 2. You very well might be on dialysis at that time. So I actually think that, over the pandemic, a lot of mental health professionals have moved to telehealth and teletechnology. And I actually think that's a real step forward for a lot of dialysis patients who have access issues. But I think ultimately, this is a really complicated question, and it should not be kind of turfed out in the sense of, well, the nephrologist is kind of done with this. Maybe it's fatigue, but maybe it's depression. Let's go see what the community psychiatrist or the community mental health professional thinks. This is really an interdisciplinary decision, I think, about how to move forward with the patient at the center of that. What do they think is happening? What does the nephrologist think is happening? What does the mental health professional think is happening? And then really creating a list of options from the things that you think are most likely to be helpful, and start working your way down. And there might be some things that the patient is not interested in trying, even though you might think it might be fruitful. And then, kind of collaboratively amongst the patient, mental health professional, and nephrologist, kind of prescribing a course of action. And that's usually not, a single step. It's an iterative process. We have to try something, see how it works, and then evaluate it. And then if it works, great. And if it doesn't, kind of, not giving up and just kind of continuing on with the next thing that we think that might be helpful.
Okay. So you kind of know, Dan, how these dialysis units work or don't work. And so, again, getting back to the practical approach, how could you accomplish that given the way nephrologists' time is very limited? They spend a very short time in the dialysis unit. It's not a private location to talk to the patients about sometimes these touchy things. The nephrologists are not trained or comfortable talking about these things. So, what would you suggest if we could? I mean, and again, in our community, we have the same problem. I mean, we can't get appointments, period. It doesn't matter about insurance or anything. We just can't get appointments with, mental health professionals. But assume that we do, how would that healthcare or the mental health professional interact with the nephrologist to kind of come up with a plan like you outlined?
Well, I would, there's a variety of responses to that. I think the first step is elevating the role of the social worker within the dialysis center. If they were able to focus on the kind of presenting clinical issues, and less focused on the administrative issues that are presented before them, then you would certainly have an in-house expert, somebody that would know the patient well, somebody would know if there's a change, somebody that could observe it on their own as to whether there might be time, and perhaps even having an in-house expert who is able to do some intervention as well, if they had the time to do so, in the supervision and structure to kind of provide that care, I think that would be a good first step. I think the United States is slowly moving towards a system of making the dialysis centers responsible for depression assessment and perhaps depression care. I see that as a very positive direction. And I think, if the insurance reimbursement was not an issue, there'd be a cadre of mental health professionals who could work in an integrative fashion with the nephrology care team. I don't think that's the challenge. I think the challenge is, where does that interaction happen and who pays for that interaction? That is the challenge here in the United States. But I think, in the same way that if we said, there aren't enough vascular surgeons to do, graft placement for our patients, that's not something that the community would tolerate. I think similarly, just saying that, well, we don't have these people available to us is not something that the community should tolerate, and that there should be an emphasis on providing the resources that our patients desperately need.
So for the nephrologist, and they see this patient who, clearly suffering from this complex, I guess my approach would be first to see if there are, symptoms that we can treat, medically, and try to get them in to some sort of counseling, or somebody can help them with these complex psychosocial issues. And in the meantime, if we've exhausted the physical treatments for some of these symptoms, then perhaps we give the patient a trial of an antidepressant. That's kind of what we do currently, since we can't really get healthcare professionals. A lot of times I will prescribe a trial of an antidepressant myself.
I think that's, certainly in this country, a majority of antidepressants are prescribed by non-psychiatrists, other physicians. And I think that's, a very reasonable approach. What we see, unfortunately, is that many people who are started by a non-psychiatric specialist are started on a low dose, which is probably appropriate. You want to start low, but they're not really titrated up to a therapeutic dose. And then what ends up happening is, it's kind of like a one shot. And then we say, oh, we tried that, it didn't really work. Or they've been on it for, 5 years at a subtherapeutic dose, and they're not, no one's really sure if it's helping or not helping. So I think, starting, certainly with a physician that you trust, if you are if you have an ongoing relationship with this patient and you are willing to prescribe an antidepressant, I think that's a fantastic place to start. You just want to make sure that you have kind of appropriately diagnosed the condition, and that you are monitoring, the way that you're prescribing it, so that the patient is not just getting kind of the negative side effects of the drug, but also has an opportunity to get therapeutic benefit.
And my experience has been that, for instance, sertraline is particularly a good medicine to use in dialysis patients, because it can also help with some patients who have dialysis-related hypotension. So it could be a two-for if they're getting a lot of fatigue and symptoms during dialysis from low blood pressures. Sertraline can help in some of those situations. It's well tolerated in dialysis patients. So there's been pretty good, evidence-based, looking at the tolerability of antidepressants. And they're all pretty much well tolerated in dialysis patients. And I guess the other point being that, there was a big randomized controlled trial comparing different antidepressants, and they're all pretty much equally effective, but they're not equally effective in any given patient. So if one medicine doesn't work, and either you've escalated to, a good dose, maybe even the maximum dose, and they're not having side effects but having no benefit, then you just switch to a different one. And it doesn't really matter if they're new, expensive, cheap, old. They all have the same efficacy statistically in a huge population. Although for that individual patient, you don't know ahead of time which one is going to work.
I would agree. And some of the psychiatrists that I work with, that I think of as being really excellent psychiatrists, it's not so much about their first guess as to which drug might work. Everyone might have a similar first, plan A. It's really about the speed with which they will move to plan B, and the kind of confidence that they will be able to tell the the patient, just because that didn't work, that doesn't matter. Let's try this. It's just as equally likely to work, or it might be, more effective for you. And like what you said before, the SSRIs in particular have a lot of effects that, that are not only on depression, that might help a lot of the other presenting problems that are common in dialysis patients. So, I think, the hard part isn't the science here. The hard part is really just the implementation of, getting the physicians and the patient to be on the same page about, what the best treatments are.
Yeah, no, I totally agree with you, Dan. Great. Thank you.
On behalf of our audience, I want to thank our presenters for their excellent presentations, as well as handling of the questions and answers today. This webinar was supported by an unrestricted educational grant from Vifor Pharma. At this time, we will end the webinar, and you may now disconnect.